We shall now go on to our next speaker, Dr. Shailesh, who is a consultant in cataract and glaucoma from the Eye Foundation Group of Hospitals at Salem. And he has another interesting video for us to see. On to you, Dr. Shailesh.
Very good afternoon, one and all. At the outset, I would like to thank Chairperson ARC, Dr. Chitra ma'am, and the committee members for the opportunity. I would also like to thank members of the expert panel and the moderators present. So next few minutes, I'm going to be talking about the horizontal chop and the associated choppers. I call them the unsung heroes. That's because neither as much as compared to the vertical chop, horizontal chop is much in clinical practice. Nor it gets a dedicated session pertaining to it. We hardly get to hear about it when we are talking about the various chop techniques or when we are comparing it with the vertical chop. So let's see what all horizontal chopper can do in various scenarios. When we look at a cataract like this, almost a clear cataract, except for an isolated PSCO, one thing that comes to a surgeon's mind is the issue of cheese wiring, be it while you are trying to rotate it or you are trying to crack it. Now, let's see what a ball chopper or a horizontal chopper can do when assisting us with the rotation. What I usually tend to do is kind of take the second instrument of the ball chopper, engage it at the lens equator in this manner, then gradually swipe across, mechanically separating most of the lens matter in that quadrant against the lens capsule. Once major part of it is been separated, the rest of the lens matter just joins along and gets rotated without actually getting cheese wired. Now, with the issue of cheese wiring associated with the chop or crack of such a soft cataract. Now, with the use of a ball chopper, we actually need not have to crack or chop it. We can engage the lens equator in this manner with the second instrument, and actually using a phaco tip itself as another instrument, we can mechanically separate them. This is the wedge mechanical separation of the pieces. We repeat the same maneuver by rotating it by 90 degrees. We can use the phaco tip directed either towards the right or towards the left while we are separating the pieces mechanically. In this manner, without the use of even an ounce of phaco or a vacuum, we actually have 4 pieces with us, which can, being the soft nature of the cataract, can then be easily emulsified in no time. Now, with the added confidence of the ball chopper sort of guarding the PC, I went on to sort of dare to, get the cortex aspirated with the phaco tip itself. Now, if you see, the second instrument is sort of placed posteriorly against the PC, guarding it against being sucked up, and I go ahead aspirating the cortex safely. Although not a advisable or a safe procedure, I went ahead and I was able to do it just because of the safety of the ball chopper. Yes, sir. For this, we actually wedge mechanical chop can even assist you in a situation wherein the cataract is neither too soft nor too hard to be cracked. We can easily separate them mechanically in this fashion. The same technique can thus be employed for a relatively harder cataract as well, mild to moderate grade cataracts, wherein without use of vacuum or a phaco, you can just mechanically separate them. Now let's see how a ball chopper can be used in a harder cataracts with grade 3 and 4 and beyond cataracts. The technique employed is that of known as the submarine chop, wherein first we sort of engage the nucleus, the deepest part of the nucleus with the phaco tip. Once this is done, once we get a firm grip onto the nucleus, the second instrument wraps around the opposite equator. At this point, it stays firm there. The nucleus tip then traverses through the substance of the nucleus like a submarine and subsequently gets chopped. Let's look another example. A trick at this point would be to sort of push the nucleus away using the second instrument in this manner so that you can engage the most peripheral part of the nucleus into the phaco tip as possible. Once this is done, once a subsequent amount of depth is reached and a firm grip is obtained, you go ahead engaging the opposite equator with the second instrument. At this point, second instrument needs to be held firm. The phaco tip traverses through the substance like a submarine. Once you cross a point beyond the center of the nucleus, you just crack and laterally separate. Now let's see a case of hypermature cataract. I usually begin by aspirating the liquefied cortex using a 24 gauge needle. Then comes the difficult steps of doing a CCC. If you end up getting a decent size CCC, all you see is a dense small nucleus left behind, which tends to dance around. If the antechamber permits, my preferred technique in this would be to sort of get the nucleus out of the bag in front of the bag complex. Once this is done, before at this point getting in with the phaco probe, the second instrument needs to be placed behind the nucleus so as to prevent it from being pushed below posteriorly with the gush of fluid. Now at this point, the easiest place without the piece being running around to hold on to such a small piece is the center, which I'm doing here. Once you get a good grip with the safety of a ball chopper, you sort of blindly go behind the nucleus piece towards the center in the opposite pole and can easily chop it. Once you get these two pieces, you can go ahead subsequent chopping and emulsification. And let's look at a mature cataract and how we go about doing a horizontal chop in this. So the first point to note here is to have a firm grip onto the nucleus piece. Once you held on to it, gradually retract the phaco tip, phaco probe towards yourself. So you tend to visualize the equator of the nucleus. Also, gradually lift it a bit, pushing sort of getting it away from the PC, then go around the equator and chop with the horizontal chopper. Let's look again. Have a firm grip, lift it, push it yourself, pull it yourself, and just chop it. With these maneuvers, once you end up getting a multiple pieces, the situation you are left with is to deal with two set of pieces. One set of pieces in front of the phaco tip and the other lying in the bag. So dealing with the phaco pieces in front of the phaco tip is by appropriate phaco parameters and adequate foot pedal control. Without causing much chatter, you can take care. At this point, the second set of pieces in the bag are kept in place, are kept in check by the second instrument. As you can see here, it is sort of keeping the pieces in discipline within the bag, while the other pieces are being emulsified at a plane anterior to it. At this point, as you can see, the second instrument, in addition to keeping the pieces in check in the PC, is also sort of preventing the posterior capsule from being tented up due to surge that typically happens during this stage of the surgery. The situation right now is more scarier with a bare PC looking at you. But with the PC ball of the ball chopper guarding the posterior capsule, you can sort of have a peace of mind while you are eating it gradually. Patience is a good virtue to have in a situation like this. At this point, the second instrument is guarding the PC while you are eating the last few pieces, which is a little tricky and risky. You can even go ahead and remove the small piece lying at the side port while the ball chopper is guarding the posterior capsule. I would like to end my talk with a small clip. This clip was just for a fun part of it. I do want comments from the members of the expert panel, and I do want to emphasize I do vertical chops as well, and though a bit tedious, with a little intimidating, horizontal chop is a good technique one should be well versed with. Thank you.
Yes, Shailesh, that was an amazing video. I think you convinced us that we should buy a ball chopper before you buy a phaco machine either.
I think, yeah, Shailesh, I think it was excellent. And the best part is that you explained everything so convincingly and so well. I think you should do a video atlas of phacoemulsification surgery, because it's very difficult to do the way you explained. It's not easy.
No.
And
you,
very, very nicely, beautifully explained.
Yes. Thank you, ma'am. Thank you, ma'am.
In opinion of the expert panel, all of you all could tell what you would want to add to what he's shown. A lot of gymnastics. Dr. Sandeep?
It seems.
Yeah, I think we are all mesmerized by that beautiful video. Yes. If at all any comment would be made, I think in that last, when he was coming to that last piece, when you had to remove that last piece, small fragment, I would advise you to keep the ball chopper right across the pupil, That way you can prevent the posterior capsule from moving forwards rather than keeping it just below the piece, because the capsule can move up. So maybe I might probably, otherwise I think this was a beautiful treatise on horizontal chop. I think you covered all points so beautifully.
So what about subluxation, mild subluxations? Would you use your ball chopper to do more magic here too?
If I happen to get a good grip onto it, definitely, ma'am, should be safe. Shouldn't be a problem, I feel.
Would you want to use a larger rhexis? I feel in some of these eyes, And,
harder cataracts, yes, ma'am. One for a harder cataract, one more thing I do is at the my rexis would be sort of D-shaped, longer towards the opposite pole, wherein I will be going with my ball chopper underneath. So that part of the rexis I sort of tend to make it a little larger, which facilitates me going underneath the rexis margin. So that's one thing for a harder cataract. Apart from that, for softer cataracts and matures, I usually don't alter my rexis size.
I wanted to ask you on one thing with the submarine chop that you described. Do you think, I mean, at all the times you may not be able to gauge what is the hardness of the cataract, and if it's a hard cataract, that submarine chop is, you know, good because it's kind of blind and you're not seeing where you're going inside. But if it is not a very hard cataract, then it might just, you know, give way also. So do you think you need to be careful about that, especially the submarine chop?
I think
Yes, ma'am.
submarine
The
chop
phaco
will have a
Definitely.
larger axis and
Ma'am,
it's like
submarine-
the lens is made to stand vertically, right?
No, horizontally. Horizontally, from the two sides it is coming. The submarine.
I didn't get you, ma'am. Hello.
No, I thought that in a submarine shop, you need to have a little larger axis
Yeah, absolutely.
and the lens is sort of tilted. No, it's like a lens salute kind of situation.
No, not necessarily, Chitra. You know, you can have, you don't need a tilt. You need to ensure preoperatively on biometry.
Ma'am,
that
the main thing
lens
is the
adequately
firmness,
thick.
the firm.
Thick lens.
Yeah, because if the lens has adequately thick, then it's quite safe to go. And with a hard cataract, you can avoid the amount of phaco energy because most of these are just mechanical fracturings that take place, you know. So getting the two instruments together, described various ways by various techniques, but eloquently described over here.
Excellent videos, Shailesh. I mean, if you have to comment a couple of points, I mean, maybe I would have the
It's tough, ma'am.
Can you hear me?
Yeah.
Yes, we can.
No, I said excellent videos, Shailesh. I mean, if you have to make any comments at all, one aspect is that, especially for the harder cataracts, maybe I would have the phaco tip a little more exposed. You know, I found that the exposure of the tip was a little less, and the amount of depth to which you can bury your tip into the nucleus is limited by the length of the exposed part. So a little more exposure would have helped. And second thing is maybe in the harder cataract, I would have
Said, sir. Yes, sir.
slightly deeper trench so that you can really get a hold on to the meat of the nucleus. And then that's what you tried to explain. I would have made a softer cataract may not be necessary. And third aspect is, though classical teaching of horizontal chop is to go to the equator and bring the chopper and the vessel close to each other, I think most of us nowadays don't go right up to the equator. We go under the rexis margin and then bury this thing and draw it, and then most often it works. Because especially younger surgeons might find it intimidating to, if you tell them that every time you have to go right up to the equator to do a horizontal chop. It can be, though you managed it beautifully, it can do it just by going a little beyond the rexis margin and then going ahead and completing it. But otherwise, very nice videos.
But this kind of complete fracture would happen if you go further in, which is shown beautifully well. Very good.
Definitely,
surgery.
sir.
Yeah. Dr. Mahipal, you want to add anything?
Yeah, so Shailesh, I think excellent presentation. So as they say, there are 100 ways to skin a cat, and the horizontal chop, basically, you made the end a little more bulbous than the Nagahara classical chop that was described, right? And essentially, as what is important, or what he showed in all his videos, is that you can handle almost any grade of cataract depending upon
Yes,
how deep you have to go and where you have to go. And great, I would say that you have done great. And I think phaco has become much easier than when it started with the new machines and the fluidics and the dynamics that you have of a stable chamber, and then you have new choppers. So I would say that, again, as Namrata said, I'll echo that it's a great teaching for the uninitiated or even the initiated phaco surgeons. So keep up the good work. I think great, and you did explain the nuances pretty well. And congratulations on a great video presentation.
Thank you, Shailesh.
Thank you, ma'am.
Yeah, so